attorneys, judges, or legislators how to go about establishing a patient's 60-day supply. If a patient needs more than whatever that presumptive amount is, that's up to a lawyer and a judge and a legislator, any of them, to decide what that is. And the Department of Health should limit the scope of its inquiry into what a 60-day supply standard should look like.
We're at 3 minutes.
Wow, okay. I'll come back to the other stuff later.
Oh, man. I'm going to have something to go on, Allison. Gosh darn it. Anyway, I'm Dale Rogers. I'm Executive Director of Compassion in Action Patient Network. I first got started in the medical marijuana business and understood that medical marijuana was medicine back in 1992 when I worked at the University of California at San Francisco, Ward 86. It was the #1 AIDS cancer research clinic, and we had about 3,000 patients a month come through there. And I met this little old lady named Brownie Mary, and she came in every Thursday afternoon, and she provided her boys who had AIDS with brownies loaded with marijuana. I've been living with AIDS now for 21 years. This is my 21-year anniversary, so we have a panel up here of survivors, and out there too. And yes, there is something in common, and it's been this medicine that we have used. There is something behind it. And one thing is, in the AIDS industry, we've always had to, in the early days, we had to roll up our sleeves. We had to do the work ourselves. If a doctor wanted an x-ray from an AIDS patient, he had to put that AIDS patient in the wheelchair, wheel him down to x-ray, and do the x-ray for himself. We've come a long way with that stigma, but here we are with the medical marijuana issue. And the hardest time I'm having trouble, I was there to help write the first bill. I was in on the second on legislative. And the hardest thing I'm having to deal with is putting the burden of proof on the sickest of our society. They don't have the time or energy to do it. My doctor doesn't have 20 to 30 minutes to sit on hold while he's with the Department of Health saying, oh, can my patient have 1 more ounce? That isn't his role. So what we need to do is we need to come up with some good guidelines based on science. And luckily, this guy right here next to me is one of the top guys in the field, and we're lucky to have him in our own backyard. And we need to capitalize on that, and we need to really listen to what he has to say, since he's devoted a lot of his time into research. And thank you very much, Sunil. But this means a lot to the patients of Washington State, and we've been providing for each other for over 15 years, even before there was a law. I started off with Green Cross too, but in 1998 I stepped out on my own, and I started out of a gay HIV organization, which I still am, but I don't discriminate, and I invite everybody else into the clinic also, as long as you have bona fide paperwork. But one of the things is we've got to be able to let patients grow and provide for each other. And the most important thing too is stopping the arrest. I'm really tired of hearing we need to take baby steps. Well, who has a 12-year-old child and taking little baby steps? We need to stop the arrest. We as patients and providers in Washington State have proven ourselves with the law for the last 10 years.
We're at time.
We're at time. Okay, well, that's enough. Anyway, thank you.
And Sunil.
Thank you, Dominic. My name is Sunil Agarwal. I've been doing a PhD work at the University of Washington studying cannabinoids and cannabis and their medical use in Washington State. And I was in the midst of those projects when the 6032, the revamping of Washington State's law started happening. Initially, I was sad to see some things bargained out of there that could have helped protect patients better, such as arrest protection and group cultivation and prescription equivalence, things that could have really helped patients. But I was happy to see that the Department of Health was tasked with a scientific and medical evaluation of the question of what would be a presumptive 60-day supply. So I set my efforts towards trying to help address that question using some of the science that I've been studying and working with my mentor, Dr. Gregory Carter, and Dr. Kiyoshi Natosha. We looked at the question of the 60 days per supply and tried to base that on the longest-running cannabis medical program in the country, which was the federal compassionate IND program in Mississippi, which has given about half a ton of cannabis to patients for the last 30 years, and supplied cannabis to about 32 American clinical trials with cannabis. So that would be the place to go. So we wrote a paper in Medscape General Medicine, submitted it to that journal, peer-reviewed, and it was published in September of last year, which basically tried to use those dosing guidelines from that federal program and then try to convert that to oral administration, because just like Dale was saying, a lot of patients will eat brownies. Well, that's basically a fat extraction of the same cannabinoids. And a lot of patients don't prefer those kinds of methods versus the smoked combustion inhalation. So we figured that since the federal program is only catering towards combustion and inhalation, we should just convert that using the best pharmacology knowledge that we have to what it would be equivalent for an oral administration. So the Department of Health agrees with the idea. They've put in a significant legislative analysis on their website, and they agree with the idea that we should base this on the federal program. That's great. They also agree with the idea that their patients prefer other routes of administration, such as oral administration. But unfortunately, they just throw a couple of extra ounces onto their number to allow for that. And that's where the science can be a guide. So they recognize that patients should, on average, the IND program, the federal program, allows 17.5 ounces of cannabis for a 60-day period. So all you need to do is multiply that by 4, which is the standard on basically on all the congressional records on the science of cannabinoids, and you can get the figure of 70 ounces, 71 ounces, that ballpark. Unfortunately, the Department of Health says that that would put patients at risk of arrest, of robbery.
And we're at time.
We'll talk later.
This whole time limit thing has really proven to be a bummer. Nobody's really
You
getting
can talk
involved.
for 30 minutes, Douglas.
I can assure you I don't have 30 minutes worth of material this morning. The heat has made my brain not work. I just want to remind everybody to drink water like camels at the Oasis today, because it's going to be way too hot. I've been defending patients here in Washington State on using marijuana as medicine since before we had a law, and I'm going to be continuing to defend patients, it looks like, for about the rest of my career unless we can get this mess straightened out. The current situation in the Department of Health is such that I don't believe that the proposal that they have in front of them, or that they put out, if that proposal stays the way it is, I don't think we have any choice but to sue the Department of Health to prevent the imposition of the policy, because the current policy that allows for 6 plants and 12 immature plants, and you got to measure them and all this kind of stuff, is not going to work for patients in Washington State based on my experience. Every single patient that I have represented, every single patient that I know is not in compliance with the guidelines. So, I've talked with the ACLU. They're concerned about the doctor provision. They're also concerned, I think, about the plant count provision. They may be okay with the 24 ounces. I'm not. I think we need to stick with the